So just to start with, if you haven't seen this, the point is that when we do valve and valve TAVR, the smaller the surgical valve, the higher the mortality, and we think this is related to patient prosthesis mismatch. I wanted this to be more nuts and bolts about bioprosthetic valve fracture, so I'll just start with a sample case. This is one of our first cases, a 21 millimeter Magna valve with severe degeneration and stenosis. The true internal diameter of that valve is 19 millimeters, and we treated it with a 23 millimeter core valve. These are the baseline hemodynamics. The mean gradient was 36, and the valve area was 0.8. And after valve and valve TAVR, the mean gradient was still 26, and the valve area only increased to 1.2, which is suboptimal to say the least. Implant depth is important, so this was our implant depth. It's a nice high implant just like we want, but the hemodynamics are not good, and so we did a bioprosthetic valve fracture, and you can see the waist give there. So just, who's done this? Okay, not everybody. Good. So our final hemodynamics after fracturing the valve were a mean gradient of 9 and a valve area of 1.6, which is much better. And we published a little bit about this. These are 15 cases in which valve and valve TAVR was done and then followed by BVF. The baseline mean gradient went from 42 to 21 with TAVR and then down to 7 with BVF. The valve area went from 0.6 to 1.0 with TAVR and then to 1.8 with BVF. So it works. But how do we do it? We need to know a little bit more. We need to know a little bit about how valves fracture. So these are two fractured surgical valves, and you wouldn't know it by looking at it because the Dacron sewing ring remains intact. Okay, so that's important. There are no protruding elements when we fracture a surgical valve. You have to dissect the fabric to see that the internal, valve ring has fractured. If you look at a CT reconstruction, this is another Magna valve, and you can see that there's a single fracture point and that the rest of the ring is otherwise intact. And, so the nuts and bolts about how to do this. If you want to perform a bioprosthetic valve fracture, first we need to know if the surgical valve can be fractured. And this is a chart that we published that basically shows, that green is good. If it's green, it can be fractured. Red is not so good. But some valves can be remodeled. They can't be fractured, but they can be remodeled. This is a term I'm going to try to coin now. Okay, so BVR.
There you go.
Bioprosthetic valve remodeling. So certain valves can be fractured. This center column, these valves can be stretched. So the older CE valves, this new Inspiris valve, if you haven't seen it, has an internal ring that can be stretched. These older generation Paramount valves and the trifecta valve, the post can be flared with a high pressure inflation. So some valves can be fractured, some can be remodeled, and then there's this last category, the Hancock 2. Don't try this at home. The Medtronic Avalis, the new Medtronic valve, these valves can't be fractured or remodeled. So remodeling, here's just a video. Look at this old CE valve and look at how much it stretches with a high pressure inflation. The waist is completely gone at the end of this. So this is very doable, okay? You just need to know what valve you're treating and where it falls in the spectrum. What you need is a non-compliant balloon, a large syringe, an inflation device, and a high-pressure stopcock. We have the little notation here that this is off-label. And then the setup is simple. So we hook the balloon up to the three-way stopcock, the syringe, and the inflator. We turn the stopcock onto the syringe, and we, rapid pace, and we do a hand injection to inflate the balloon, just like doing a BAV. And then when the balloon is inflated, then we're going to turn the stopcock off to the syringe, onto the inflator, and we're going to dial up the pressure to the fracture threshold of the valve that we're trying to fracture, or just to a high pressure if we're trying to flare the posts of a trifecta or stretch a CE or an old Paramount valve. How do you know the valve is fractured? This is very important. The pressure will drop. Okay, so as soon as the waist gives, as soon as the ring fractures, the inflation pressure will drop suddenly, and one of two things has happened. Either the balloon has ruptured or the valve is fractured. And that is the most important thing. You shouldn't be concentrating on the fluoro or the cine to look for the waist of the balloon to release, because it can be very subtle and you'll miss it. You can look afterwards and see that. Sometimes you'll hear a snap, but you can't rely on that. So it's very important that you just understand that the pressure drop tells you you're done. Once the pressure drops, you turn the stopcock back onto the syringe, you go negative, you stop pacing, and then you can reassess. Because it is a long pacing run, and so you have to be cautious. I don't see a timer anywhere. So who are we going to treat? Patients who have smaller intermediate-sized surgical valves, certainly we know that they benefit. We've published some hemodynamic data, but we need longer-term outcomes, certainly. What constitutes a small or intermediate-sized valve? I think that depends on who you ask, but in some studies, a 21 millimeter or smaller internal dimension is categorized as small or intermediate. Certainly, patients who have a high residual gradient following valve and valve TAVR may benefit. Prior studies have defined severe patient prosthesis mismatch as a gradient greater than or equal to 20, but I'll tell you that our threshold is much lower to do this. Very common to have a gradient of 9 or 10 at the end of the case. You're happy, you're pleased. The discharge echo is a gradient of 18. Your 1-month echo has a gradient of 23, and now nobody's happy. So we have a low threshold, with our experience of doing BVF or BVR to optimize the hemodynamics during the initial procedure. Might all patients undergoing valve and valve TAVR benefit? Well, by facilitating optimal THV expansion, BVF or BVR might improve leaflet function and THV durability regardless of the surgical valve size or the residual gradient. So it's a possibility. We don't know the answer. When should we not fracture a valve? Well, again, we just need to know which valves we can fracture or remodel. If we have concerns about the anatomy, we need to know the STJ size, the LVOT size. We need to look at the coronary artery distances and assess our risk for coronary obstruction. And if coronary obstruction is a high likelihood, then maybe we need to protect the coronaries. We could do basilica. Maybe we ought not to fracture that valve. Although, I'll be honest, we have protected a coronary, fractured the valve, and then stented the left main, if the hemodynamics were poor after valve and valve TAVR. Ensure that the anatomy can accommodate the balloon that is going to be used. Assess the size of the STJ and the LVOT. Smaller balloons can be used, but higher pressure may be needed to fracture the valve if, the smaller you go with the balloon. Balloon position. So if we're going to put a core valve in and then we're going to do a high pressure balloon inflation to fracture a valve, then we need to be careful. We need to know the waist of the core valve, and we can't disrupt this waist, otherwise we'll injure the valve leaflets and cause severe AI. It appears that you can use a balloon 2 millimeters larger than this waist and be okay, but larger than that, you're at risk. So for example, in a 23 millimeter Evolute, the largest balloon you'd want to use is a 22 to do a BVF or a BVR. We also keep the balloon a little lower so that the shoulder is ideally below this constrained waist. Unanswered questions. Is it better to do BVF before or after TAVR? This could be an entire debate, so I'll just be brief. Doing a BVF first, we're avoiding a high pressure inflation inside the TAVR prosthesis, and maybe that avoids either acute or subclinical leaflet injury down the road. The con is that we might risk embolization or severe AI by tearing degenerated leaflets. TAVR first, the pro is that we can assess the hemodynamic results before deciding on whether to do BVF. The high pressure inflation ensures optimal expansion of the TAVR prosthesis. And the con is that the high pressure inflation could injure the THV either acutely or subacutely. So just a couple more things real quick. So we did this on the bench. If you fracture a 21 millimeter Magna valve and then you put a 23 Evolute in, it expands pretty well. You get a diameter of 22.9. Okay, this would be the correlate of doing BVF first, then TAVR. But if you do it with an Sapien, that's an XT, so you fracture the valve, you implant the Sapien using the Edwards delivery balloon, And you only get 22.3 millimeters. It doesn't really get to 23. To get it to 23, we had to do a high-pressure inflation with a non-compliant balloon. So doing BVF last may more fully optimize the expansion of the THV. We need to study that more. So in summary, valve-in-valve TAVR and small surgical valves may be associated with increased patient prosthesis mismatch and higher mortality. Most prosthetic valves can be fractured or remodeled with a high-pressure balloon inflation, and BVF results in lower residual valve gradients and larger valve areas after valve-in-valve TAVR. Thanks.
Incredible. Adnan, one quick question. What's the maximum you think you can stretch these? How many millimeters will it go?
Yeah, so I took that slide out because it's complicated. So the maximum is 3 to 4 millimeters on the bench. All we tested on the bench were 19 and 21 millimeter valves. And to be honest with you, we didn't test every valve to see how much it could stretch. But I think 3 to 4 millimeters is reasonable. The next question then is, so what size THV do you put in? And that's, I don't know that exact answer. Is it, so for example, let's say you have a 23 millimeter Magna valve that has a 21 millimeter ID. Is it better to put in a 23 millimeter, S3, for example, and fully expand it to 23 millimeters, which is only 2 millimeters above the ID? Or is it better to put in a 26 millimeter S3, and you can probably get that to 24 and a half millimeters, but it won't be fully expanded. Long term, which is best? I don't know the answer.
But it's still important for the coronary.
Oh, absolutely.
Like if you can measure your sinus and you got 4 or 5, then you're probably safe. But
yeah.
Incredible work.